Before administering local anesthesia for bronchoscopy, we inject 0.5 milligrams of atropine sulfate and 50 milligrams of hydroxyzine intramuscularly to reduce secretions and cough reflex. Do not use atropine sulfate on patients with benign prostatic hyperplasia or glaucoma. Use hydroxyzine only. Usually, 4% lidocaine is sprayed for local anesthesia. Administering the anesthesia is easier if you have the patient sit on a chair in such a way that his face is raised just enough to sniff. This will keep the airway straight. Ask the patient to relax his shoulders. While holding the tip of the tongue with gauze, spray the anesthetic from the base of the tongue, directing it toward the vocal cord and trachea. The most efficient way to apply the anesthetic is to synchronize your spraying with the patient's exhalations. The patient will find that the anesthetic tastes bitter at first. After repeated spraying, the bitter taste will start to go away. Ask the patient to let you know when the bitter taste disappears. This means that the anesthetic has started working. Younger patients have a strong cough reflex, so a larger amount of local anesthetic should be used. Similarly, a stronger premedication such as pentazocine is sometimes used. All items that will be required during the procedure should be prepared beforehand and placed close by so that they can be readily accessed by the bronchoscopist. Use a percutaneous oxygen monitor to monitor the patient's general status during the examination. There are two basic techniques used to insert a bronchoscope: transoral insertion and transnasal insertion. Transoral insertion can be performed using a tracheal tube or by inserting the scope directly into the trachea. We usually use the transoral method because it's easier to insert and withdraw the scope during the examination, and because it ensures that the airway is maintained. For insertion, we use cuffless tracheal tubes with an outer diameter of 8 millimeters. Insert the bronchoscope into the trachea and apply the anesthetic with a spray catheter. Extrude the spray catheter tip far enough from the tracheal wall to prevent the cough reflex due to contact with the scope. Then spray the anesthetic on the trachea and the left and right main bronchi. When 1 millimeter of the anesthetic is injected into the catheter, spraying can be repeated about 10 times. Using this spray catheter lets you reduce the amount of anesthetic used. Because the anesthetic is sprayed in fine dispersed droplets, there is less coughing than when the anesthetic is directly injected into the instrument channel. Also, since only a small amount of anesthetic is sprayed each time, you don't have to suction the anesthetic right after spraying it. Once a satisfactory anesthesia has been obtained, we proceed to observation in the bronchi. Turn the scope to the right and insert it into the right main bronchus. Let's enter the upper lobe bronchus and observe the B1 to B3 segmental bronchi one at a time. Here is an inferior view from the truncus intermedius. As we advance deeper, we can see the middle lobe bronchus. Let's observe B4 and B5. Now we are going to go back to the truncus intermedius and enter the lower lobe bronchus. Let's take a look at B6 first. Now let's look at B7, B8, B9, and B10 in turn. In this procedure, we can observe as far as the subsegmental bronchi. Let's move on to the left bronchial tree. Here is the left upper lobe bronchus. We'll look at the upper division bronchus and lingular bronchus. Now, we'll move on to the lower lobe bronchus and observe B6. Finally, let's observe B8, B9, and B10 in the basal bronchus.